Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Today on the AUA Inside Track podcast, we'll be discussing the unique Morbidity and Mortality program at the University of California, San Francisco. We'll be hearing from Dr. Max Bowman, who as a resident was very involved with the initiative to revamp M&M at UCSF and remains very involved in the program's evolution. He is joined by Lynn Leng, a current medical student at UCSF who is involved in research initiatives related to their M&M program. Starting out, I'm Kayla Graham. I'm your host. I'm a PGY4 from Atrium Health Carolinas Medical Center and your Southeastern Section representative to the AUA Residents and Fellows Committee. And I'll have both of our guests today give us an introduction on themselves and how they came to be involved in this program.
Great. Thank you, Kayla. I'll start. I'm Max Bowman. I'm assistant professor at the University of California, San Francisco in urology. And I, as you so perfectly mentioned, I was sort of looped in to help redesign this during my research year of residency. And it became an initiative that I was really, really interested in and kind of sparked a lot of my post-residency trajectory. And I've since kind of continued to be really involved in M&M process redesign here at UCSF and also some other places, which we'll get into shortly.
Hey everyone, my name is Lynn. Thank you for having me. I'm currently a fourth year of a 5-year combined master's and MD program through the Joint Medical Program at UCSF. I really became interested in this project because I have a couple of different work experiences in healthcare consulting, clinical trials research, and the health finance startup world. My work and clinical interests sit at the intersection of health, education, policy, and technology. And I was really happy to be involved in this project because I thought it was so innovative and directly ties into trainee education.
Perfect. Well, thank you both so much for being here with us to share a little bit about this unique aspect of your residency program. But before we get started specifically talking about your program, Dr. Bowman, why do you think that M&M conference is important for residents and faculty to be a part of at any program?
Yeah, it's such a good question, and it's such a pillar of our not only our residency training, but academic urology and academic surgery, and beyond. Honestly, I think it's an important mechanism for programs that are not strictly academic either, and that's for I think a variety of reasons. I mean, the ACGME has mandated M&M be a part of the curriculum since I think the 1980s. And the reasons behind that are very sound. I think that there's clear use in evaluating events and learning from them and moving forward in kind of an effort for constant practice improvement. We kind of all know, especially in surgical fields, that to operate is to have errors. I mean, the only doctors who don't have any events that are relevant to morbidity or mortality are the ones who don't see patients. And even then, I think some of them might end up with some issues. And so I think really if you think about it from like an educational perspective and a continuing medical education perspective beyond residency, it's one of the more important things that we do as far as kind of self-evaluation and evaluation from peers and getting good feedback on your practice.
What key aspects of M&M do you think are important for all programs to include in order to have that educational aspect for both faculty and residents?
I have a lot of thoughts. Lynn, maybe you can answer the question also. Maybe you could go first and I can weigh in.
Sure, yeah. I think this is a great question. And I think about my clinical rotations just this past year. I've participated in such a range of M&M conferences. Some focus heavily on every step of the patient's care with extensive write-ups and outside specialists brought in. And others become more dominated by some heated dialogue between providers. And in those settings, as medical students, it's sometimes unclear what the key takeaway or what concrete steps we can take to improve patient safety. So what stands out to me about this new model that Dr. Bowman worked on is that the patient cases focused on very relevant clinical information and system processes while also leaving room for meaningful discussions when needed. So, at least from my perspective, it gives me insight into how residents are taught and supported. So, like, really this focus on systems change and like what action steps can we take to improve patient safety. And this is also ultimately reflects the values and culture of a training program as a whole. So, yeah.
Yeah, I totally agree with all of that. I think a lot of the key aspects really, I mean, if you like really break it down to like the bare bones, like what's absolutely, the bare minimum that's needed, you need like a non-judgmental environment and one that's open to practice change and also a lot of humility behind all of it. Kind of having the assumption that everybody involved was meaning or hoping to do the right thing, even if that's not quite what happened. And really just kind of having an eye towards improvement rather than, it being punitive or coming down to accusations. I think that's really the bare minimum in order to actually get to the heart of the purpose of the conference. And then everything else can be built on top of some of those core principles.
I agree. I think that attitude is so important to start your M&M conference with because going through rotations at various hospitals for away rotations and everything as a medical student, I feel like I've seen M&Ms that are set up more for kind of grilling residents in front of your peers. And while there is some educational aspect to that because you don't want to look like a fool in front of your peers and your attendings, it's definitely not geared towards what decisions can we make differently for patient care and for better outcomes rather than just kind of being embarrassed in front of people and learning what you can from that.
Yeah, I think nobody
Um,
learns from the firing squad technique for sure.
yeah. So UCSF went through this revamp in the last few years. Can you describe a little bit of how your M&M conference is set up and how that is different from what was previously done?
Yeah, of course. So the new process, we obviously gave it an acronym because, that's the only way that things, survive nowadays in academics. So we call it the Morbidity and Mortality process, redesigned to optimize value in education, which conveniently spells MPROVE. So we now know it as the MPROVE model. That's how it's been published, and that's how we're trying to market it, of course. And the new structure. Like I said, it was kind of like a entire like kind of like from the ground up redesign that the impetus of which was really a lot of people in our department recognizing that we weren't maybe reaching all of the goals or all of the potential of the M&M process in both like a quality improvement standpoint and an educational standpoint. So the prior state of M&M like before the revamp is probably something that's familiar to most people listening to the podcast. I think we didn't have any glaring issues. It's not like it was contentious. We were all very cordial, very professional. However, it was just the chief residents kind of selecting one or two cases that happened in the last month, just kind of on their own, whatever they kind of felt was valuable to talk about. It often was like the worst, quote unquote, event that had happened, a patient death or, a really bad episode of sepsis or a prolonged admission, or like a really kind of like big surgery or whatever. Now, while these are sometimes a little bit more of like an interesting narrative, there's not always as much learning that can come from it as some of the more, mundane sort of events. And so we that was one thing that we had sort of realized over time. The other thing is we just noticed that there were patterns just coming up year after year as residents kind of like came and went, and as there were like new waves of trainees where similar things were being presented over and over, and we were realizing that we weren't really capturing like the essence from like a systems improvement and systems thinking kind of standpoint. And finally, I think part of it was also just the discussions kind of got super off topic sometimes, or we'd spend 15 to 20 minutes of the hour-long session just talking about, post-op day one, this happened, and then the vitals were this, and then post-op day two, this happened, and the labs were this, and then, extend that out to like 60-day post-op, and then that's the end of the discussion, and there's no other discussion or learning or anything that comes from that. So that's kind of what it was like before. It was fine. I think people learn things from it, but we really wanted to really kind of capture the potential there. So the new process, the improve process, we sort of formulated several different interventions to form the new conference. The first was to design an online reporting tool that anybody in the department, from the intern to the chair to the APPs to the clinic staff, could submit M&M cases. And this way, anytime it rolled in, either to clinic or to our after hours answering service or admitted through the emergency room, anybody on the team could submit a case to our online confidential reporting that we happen to use RedCap for, because that's our most common one that's compatible with pretty much everything we do. And then we also designed and formed a committee, an M&M committee, that is made up of a variety of volunteers from the department, including faculty ranging from very senior to very junior, including from different subspecialties in urology, and also inclusive of resident volunteers as well. And what this committee does is it meets every month and it reviews the large deposit of cases in the central reporting system that we had designed. And it reviews all the cases from the prior month, and then it chooses the top, 4 or 5 that are of the highest educational value. Now, this is a pretty critical point that differs from how it was previously, because the things of highest educational value might be, hey, we had 6 UTIs this month, or we're noticing a lot of urosepsis, or hey, like it seems like we're dropping a lot of issues during handoffs or something like that. These would not have been identified or talked about or even recognized on the prior kind of unmoderated sort of process. And so that's really kind of one of the things that we're driving at. Of course, we still present the deaths that might rarely happen or whatever else it is, but it gives us an opportunity to really kind of have a global perspective and look for trends and things like that. The other arm that we designed was during the actual conference itself. We have a standardized template that the presenters use now. So instead of just the chief resident just kind of putting together some slides, there's a standardized like 4-slide template that everybody uses with a very succinct patient history, using only the relevant details, and then using the remaining 13 minutes of that quarter of an hour for discussion on why did this happen? Here's some QI tools. Here's a fishbone diagram. Here's 5 whys. Like, how did this actually come about? And what tools might we implement, or what change might we implement to prevent this from happening in the future? The other thing that is really great, that's kind of brought a lot of, I think, positive change, is we assign a faculty moderator to the discussion, who is somebody who's not actually involved in the event, who can sort of serve as like a buffer between the trainee who is presenting and the kind of like the attendees who are there to discuss the case. And they pose questions and receive questions, and they kind of form a little bit of a moderation there and keep the discussion on track. And all the moderators are sort of coached beforehand on how to do that effectively. And then the final piece is we follow up initiatives that come from these conferences and actually assign stakeholders within the department to follow up and to actually enact change to prevent these things from happening. And then what's really nice is the central database is then iterative, and we can see if there's trends or changes over time in some of these events. So that's the new process, and we're really proud of it. And it so far has actually been super effective over the last few years.
That's awesome. It sounds a lot more thorough and like it is set up to have a lot better outcomes in terms of creating an environment where you prevent those types of incidents again in the future. You mentioned having follow-up on all of those things. Does the committee meet to kind of reevaluate things periodically and check in with those stakeholders to see if things are getting done too?
Yeah, that's exactly right. So the only part of the monthly meeting of the committee is dedicated to reviewing the prior cases for the month. That takes maybe about 30 minutes, and choosing, which ones to present and assigning moderators and presenters. And then the remaining of the meeting is to follow up on prior initiatives and prior things that we had talked about at other meetings to see if there's any progress, to see, check in with stakeholders, et cetera. Sometimes we'll have people come and present and talk about things that they're doing.
Okay. And you still have the M&M conference every month?
Correct.
Okay. Lynn, can you tell us a little bit about what your involvement is with the M&M program too?
Yeah, definitely. My involvement in the research has primarily been focused on like data collection, analysis, writing. I learned a lot during the doing the research. I learned that M&Ms have been mandated since 1983. You know, I attended my first one last year. Um, and I learned from Dr. Bowman and this research that there has been a call to standardize M&Ms recently because it is so integral in training. As someone applying into urology this year, I am just curious about like how M&Ms are now done at multiple institutions, right? Like I didn't think about that before. I think during my research, I learned that 83% of residents believe that participating in M&Ms would change their future practice. So doing the research has gotten me really involved in education, a space that I also hope to be in the future, and also just reflecting on M&Ms and my current medical education. So at the JMP or Joint Medical Program, in my preclinical years at Berkeley, I've had the opportunity to take classes alongside public health students, business students, and then what stood out to me in these courses about like healthcare strategy and goal setting are things that I see reflected in the M-Prove model, right? So the way that our new M&M is structured with the emphasis on clear goals, actionable items, mirrors how effective organizations and like companies drive innovation and improvement. Even in our research, when we reference Coter's 8-step change model, which is from Harvard Business School, it's just so interesting seeing these tools used in this new model. So I really commend like Dr. Bowman and the M&M team for bringing that kind of strategic thinking into improving patient care at UCSF.
Yeah, Lynn is being quite modest. I want to just add that we're wrapping up a initiative to help spread this structure to other institutions, and so we're in the process of writing up and submitting a manuscript showing our findings that have essentially demonstrated that this process is reproducible at now 3 other institutions of kind of varying sizes. And our data, like I said, not published yet, but in a pretty well-formed manuscript right now, and it shows that the differences and the changes that we found in our institution before and after instituting this have been replicated successfully at other places. Some of those differences are greater satisfaction, greater feeling like there's educational value, greater attention to systems change and things like that. These are all the perceptions of the attendees. And hopefully in the future, we'll be able to evaluate actually how much of this is making an impact on some of our quality metrics. Obviously, that takes a little more time to evaluate. But at least right now, we're able to tell that attendees at least get a lot more out of this conference, feel more engaged, feel less intimidated, especially at more at the junior level. And that's not only true here at UCSF, which is kind of fun to see. And if there's any listeners out there who are interested, we're still interested in recruiting and spreading this as far as we can. So it's been really successful, and Lynn has been really helpful in that aspect of it.
I would also add, we also had some like qualitative results from program leaders, and it seemed like it was pretty easy to implement and overall has like a great improvement at the end. So not only do we get the training aid perspective, but it's great to also see the program leaders and administrative perspective as well.
Well, that's sort of a perfect transition. If there are other programs or residents or other faculty members that are listening to this podcast and are interested in implementing this change in their program, how do they go about that? Can they reach out to you guys and get sort of the information on all of this, read your manuscript? Are you comfortable sharing your presentation templates and your reporting templates and all of that stuff you're using?
Yeah, absolutely. I mean, the whole idea here and the hope here is that more and more people start to adopt a model like this. It's not a one size fits all. Even in the, 3 institutions we've kind of spread it to, we've had to make little adjustments here and there, which are either dependent on the department and like how they run M&M, which is different than us, or even some state laws are different on like what's discoverable during M&M. So one of the institutions we had to change a little bit about how like the cases are recorded and reported. But it's a very flexible and adaptable model, which is really great. And I would be so pleased, so happy if people were to reach out to me, just email me, max.bowman@ucsf.edu. And I would love to share all the stuff that we have. And we will also like walk through and train people how to do it at the institution and have some meetings with them. And then we can follow up and check in, make sure it's going okay. But like Lynn said, it's been met with nothing but positive feedback. And it's really not too onerous to implement. And I think overall, people are, in my experience, when we tell other people about this or when we've presented at conferences, or I've had people just cold email me after the publication of our initial manuscript, and they were like, wait, yes, like we are going through this exact same issue with our M&M. We would love to do something like this. We've been saying this for so long. And now here we've hopefully done a lot of the legwork for people if they're interested in kind of implementing this new structure. And I think departmental leaders see the inherent value to it.
That's great. Other than attendee attitudes towards M&M in general, are there any ways you've identified that this program change has impacted the urology department as a whole?
Yeah, that is a great question. We have an ongoing research initiative right now to evaluate a few things that have come from it. One thing I'm looking at currently with one of our residents is looking at some of the like character and types of M&Ms that are submitted over time to see if that's changing. Because like I said, we have like now a database of like 600 events over the last several years that we can now pull from and study. So that's one thing we're currently doing. We also have been sort of tracking certain initiatives over time to see kind of how successful that's been. Happy to talk more about what some specific examples are if you'd like. But those kinds of things are underway currently as well. And then informally, we just have like a lot of good feedback about it in general, which is, that counts in my heart at least. But
Absolutely.
like, when we have like a new fellow come from a different institution or something, like it's not uncommon at all for them to be like, oh wow, I love the way that you guys do this here compared to where I came from or something like that. So it's really nice.
Yeah. Um, yeah, if you wouldn't mind sharing with us kind of what some of those things are that you're continuing to track. It sounds like a lot of things that are input into the database have turned into almost offshoot projects and things that you're continuing to follow up on and make changes with. So, can you give us an example of that?
Yeah. Lynn and I actually were just talking about this in anticipation of the podcast, just like kind of almost like reminiscing about things. Lynn, what were a couple of the things that we had talked about? Do you remember?
Yeah, one of the initiatives we were talking about was looking at urine cultures before surgery and tracking those over time, and identifying like, oh, like who can we bring in to make this more efficient, whether it's APPs or like changing how the process works, to catch some of the infections that come after. So that one like is highly related to patient safety. That was really interesting that came out of this.
Yeah, that's a really, I think, a great example of one of the like non-sexy ones, like that's something that never would have been really like talked about before, but we did notice like, hey, we have like a bunch of like sepsis cases or a bunch, like whatever, and digging into the actual QI thing with a fishbone diagram or whatever, it was like, oh, like this patient like didn't get a urine culture in time, or this patient didn't have like exactly like targeted antibiotic prophylaxis or whatever. And that was like a great like just nugget of like inspiration for a whole like QI project. Other things, another one that I think is along the same lines is we noticed that some of the like things were seemingly unrelated, but when you dig down to like the underlying causes, some of it had to do with like information being lost during our handoffs. And so we reevaluated the way that we do like sign off and handoff between, the
Hmm.
on-call resident who might be at a different site and the day team who was passing off care of those patients. So we sort of reevaluated the way that we do that and kind of implemented a new structure there. Um, and I think that is like kind of the beauty of this process is like it is like a jumping off point for so many other QI initiatives that actually do make a big impact to the department or to our patients.
Do you have all clavien grade 1 through 5 complications that come up input into the database?
Oh, this is such a good question. The answer in short is yes. And I would say like yes plus because we actually have the opportunity to or the like we designed it on purpose so that we can submit not only Clavien Dindo 1 through 5 but also things like near misses which again like never would have really come up at all but like if we say like oh like this patient was like brought into the room and it was identified that it was the wrong patient but we caught it don't worry like we went and got the real patient that wouldn't have raised anybody's attention, outside of like a formal QI evaluation. But if something like that were to happen, we can absolutely submit that and talk about it during our M&M conference. And it's a perfect space to talk
Hmm.
about, hey, what systemic issues led to this happening? How can we avoid the holes in the Swiss cheese lining up? And instead of being so reactive to things, we can be more proactive in determining them. So if you strictly look at Clavien Dindo, that wouldn't fall on that scale at all. And
Hmm.
so not only do we submit and report events that involve patient harm, but other things too that are just like, hey, I noticed this system issue and this might be a good QI thing. Let's submit it as an M&M and talk about it. And those are actually some of the most positive ones because it's like, hey, nobody's even really at fault. Nothing really happened. But we're all kind of on one team being like, hey, let's make sure that this doesn't lead to patient harm in the future. And I
Hmm.
think that capturing that type of stuff on like a broad conversation through the whole department has been super helpful.
Absolutely. Have either of you come across anything that you can recall that was more kind of about things that are related to interactions with other departments and go from there in terms of improving things?
Yeah, I think one actually pretty recent example comes to mind. I don't know how much I can talk about really, but it's like a common thing for urologists to help out other services during their procedures, whether that's
Mhm.
putting in externalized ureteral stents or doing a cystoscopy for some reason or another or whatever. And just kind of in broad strokes, there's been a few issues that have come up, patient harm or patient delays or like, taking people away from our surgeries to go take care of other things by other departments or whatever that have sprung up some issues, not big things, but they've still kind of risen to the attention of the M&M committee. And actually,
Mhm.
very recently, we've entered into some discussions with other services, other teams to kind of problem solve and make sure everybody has their needs met in that way. So that it's not taking away from our residents' learning, but also helping with their service. And that's been a pretty successful identification through this process.
Has transitioning to this model kind of spread to any other specialties at UCSF that you've seen?
We're sort of in talks with a few others. I'm trying to market it as best I can. Ultimately, I would love for this to be like almost like a institutionally recognized thing, um,
Hmm.
just simply because I believe in it so strongly. But yeah, I think other people have been really interested in it, and I think we're kind of generating some interest here and there, and hopefully we'll adopt it some more.
In closing, what do each of you want listeners to take away from this episode regarding M&M in general or your specific model, and things that can be gained as an individual and as a department from an M&M conference?
Lynn, what do you think? You go first.
All right. I think there's so many good nuggets from being on this project and from doing this podcast. I think being open to a new process is really hard, and talking about our mistakes is really hard. Um, but this M&M and improve model makes it that we can be goals oriented and learn from whatever mistakes or systems issues that happen and ultimately have that one goal of improving patient outcomes and safety. This is the first time I've seen it done really, really well. And I'm hoping that, wherever I go for residency, it can be, replicated there and any other training places because I truly believe that this is just only for the good. So I think one thing to take away is just be open and yeah, try the improved model out.
I think a lot of places or a lot of people may lose sight of like actually what M&M is all about. And it really is about patient safety and it's about education. And there's plenty of research, and it's, I think, generally accepted, really, that those types of that type of growth happens really in environments that are not punitive, not judgmental, are full of humility and full of kind of open-mindedness. And it is really a returning to what M&M and quality improvement and systems improvement really is supposed to be about. Um, and I think in the end, I think the most important message here is just kind of to kind of think about, what the goal is here and how we can best reach that together.
I think both of you brought up great points in that, in the sense that it's really hard to talk about your own errors and misses. And I mean, we all went into medicine to treat people well and to help people. And so knowing that bad things happen and are inevitable to everyone, it's hard to come to terms with that, and especially to present that and talk about it in front of all of your peers. So it's super important to have an environment where you feel comfortable and safe doing that and supported in doing that, and being able to use that as a jumping off point to improve your practice, improve your department, and improve everyone that you work with. So I think you guys have done a beautiful job of creating that environment, and I hope that you can continue to share it with the rest of us in urology and in other surgical specialties too.
Thank you. Yeah, the last thing I want to say is I really want to thank our senior leaders at UCSF for being open to this and also being such good examples, because the culture really flows from top down. And without them being humble enough to say, hey, I messed up on this case, this is what I should have done better, and being open to other people stepping in, and even no matter if it's a junior resident or a junior attending or whomever, chiming in and saying, these are my thoughts, and them being open to that culture at our department has allowed this to flourish. And I am so thankful to them for doing this. And the funny thing that we see now is a lot of attendings that have things happen, like, encourage the cases to be submitted. They want to talk about it. They like email the M&M committee and they're like, hey, please select this case to talk about, because they want people's feedback. They want to hear what people would have done differently. It's purely educational. Not a single thing about it is punitive at this point. And instead of dreading your thing coming up, you look forward to it, because you know that everybody just is there to help chime in and teach.
I think that's wonderful. And I think that speaks to the type of program that you've created, which sounds like a really great learning environment. Well, thank you, Dr. Bowman, and thank you, Lynn, for joining us today and explaining a little bit more about your improve model, and kind of sharing with all of us how that has changed your program and your practice, and how they can get in touch with you to implement it in their own programs.
Thank you so much for having us.
Thank you, Kayla.
This has been an AUA News Inside Track podcast, brought to you by the Residents and Fellows Committee. For more information about the AUA and AUA membership, visit auanet.org/membership.